When we're deciding on the best treatment for an individual with breast cancer, one of the things we think is the most important is to recognize that there are several different kinds of breast cancer. And each kind of breast cancer has its own characteristics and, importantly, its own sensitivities to different types of therapy. So in the old days where we used to treat all breast cancers the same, we realized that that really made no sense, and now we try to tailor our therapies specifically to the kind of breast cancer a person has. We think of mainly three different types of breast cancer. One is driven by estrogen, another is driven by a protein called HER2, and a third we call triple negative is most sensitive to just chemotherapy alone. So HER2 positive breast cancer is particularly interesting because as it develops, it has a mutation in its DNA that leads to dramatic overexpression of this protein called HER2. HER2 is a protein that sits on the surface of cancer cells and basically sends a signal into the cell to grow faster and become more aggressive. And because these cancers have way too much of this HER2 protein, they're driven by this protein to become more aggressive. So a HER2 positive breast cancer is more aggressive than some other types of breast cancer, and it used to be one that we didn't like to see because of that. But once it was recognized that the reason these cancers behave like that is because of this HER2 protein, it led to the development of drugs that specifically block this HER2 protein. And the first of those drugs was called trastuzumab, also known as Herceptin. And once we started using these HER2 drugs that basically block the thing that's driving these cancers, we found that those cancers now actually have better outcomes than other kinds of breast cancer because we're able to block the thing that's causing the cancer to behave aggressively. After Herceptin was developed, we now have had several other drugs developed that also block HER2, and these also seem to be quite beneficial. So the reason we care about HER2 is because it allows us to use these HER2-directed therapies. Because we need to know which cancers are HER2 positive, we need to be able to measure HER2. And we do that in two different ways. One is to see how much HER2 protein is on the surface. We call that IHC analysis. And those cancers that are HER2 positive are called HER2 3+ by IHC. There's another test that actually measures this mutation, which was called amplification in the DNA, and that's called the FISH test. And those cancers that have high amplification of the HER2 gene by FISH is another way to recognize the cancers that are HER2 positive. So you can identify a HER2 positive cancer either by the IHC test or the FISH test. It doesn't really matter. Both are telling us that this is a cancer that we can use these HER2-directed therapies, and that's really led to a pretty dramatic improvement in how patients with this kind of cancer do. When someone has what we call metastatic HER2-positive breast cancer, it means that the cancer has spread beyond the breast and the lymph nodes. That typically is not curable in the sense that we can give some type of treatment that's going to get rid of every last cell, but it's very treatable. And our goals of treatment are basically to keep the cancer in the background and prolong survival and maximize quality of life so patients can get back on with their normal activities. We do that with drugs that block HER2 because this is the protein that's driving these different cancers. And by blocking HER2, we can significantly improve the effectiveness of our treatments. Generally, for most patients who have newly diagnosed metastatic HER2-positive breast cancer, we use a combination of chemotherapy plus two different HER2-blocking drugs. One is trastuzumab or Herceptin, and the other one is pertuzumab or Perjeta. It's been shown in large clinical trials that that combination is both highly effective and better than using just one HER2 drug alone. So that's become our usual go-to regimen for those patients with newly diagnosed disease. In some patients, eventually those cancers become resistant to that combination and we need to switch to a different treatment. There we use an interesting drug called TDM1 or Kadcyla. TDM1 consists of basically trastuzumab along with a chemotherapy drug. but the two are attached. So the trastuzumab basically brings the chemotherapy directly to the cancer cell. It's kind of like a guided missile in that it directs the chemotherapy directly to the cancer cell and keeps the chemotherapy from damaging normal tissues. So TDM1 allows us to both target the cancer cell specifically with a very potent chemotherapy drug and also reduce side effects because the chemotherapy is directed directly to the cancer cell. So people on TDM1 don't have typical chemotherapy side effects like hair loss or severe nausea or neuropathy. So it tends to be a pretty tolerable treatment, and it's been shown to be better than other standard drugs and improve survival. So for most patients, after trastuzumab and pertuzumab stop working, TDM1 makes for a good choice.